Good morning, everyone. I think we're going to go ahead and get started. So if everyone can take their seats, I'll have Dr. Sanusis introduce our speaker in a moment. Just to remind everyone that the next 2 weeks we have outstanding speakers. We're very fortunate. No pressure, Juan, that you will be followed by Dean Nancy Brown, who will be giving the Moser Lectureship. We're very pleased and proud that we were able to get Nancy to present her first major grand rounds with us here in cardiovascular medicine. So she'll be speaking next Tuesday at 8 a.m., and I would hope that we will give her a very strong welcome to Yale. Following that, I believe we have Chris Longenecker from Case, who will be presenting some of his work on HIV and cardiovascular medicine. Chris has done a tremendous amount of work in global health as well, and we're excited to have him visiting with us as well. So we have a great lineup, including today's speaker. And Al, I'd like you to introduce it.
So it's my pleasure to introduce Juan Lopez, who received his medical degree from Ponce School of Medicine in Puerto Rico, and then did his internship and residency in cardiology fellowship at San Juan in Puerto Rico, and then moved to the U.S. and to Houston, to the Methodist Hospital, where he trained in multimodality imaging for 2 years. And he's one of the unique people who is boarded in medicine, cardiology, nuclear, echo, MR, and CT. And he's level 3 in echo, CT, and MR. He's now an associate professor at the University of Texas at MD Anderson, where he is the co-director of the cardiology, radiology, imaging services at MD Anderson, and has kind of a growing leadership role in multiple societies, the ASC, the SCCT, and the SCMR. And his research is focused on multimodality imaging and really cardio-oncology. He already has 60 publications and 20 in the last year. So join me in welcoming Juan to the podium.
Well, thank you all for that kind introduction. I'm very happy to be here. So let's get started. These are my objectives. Okay. So I just want to start this as a conversation between us, because I just want to highlight the concept of multimodality imaging, where this came from and where we're moving, what's the future of imaging, right? And it's very interesting how the great Dr. Anthony De Maria had some predictions from 2005. And in this, one of these predictions, I mean, he was really on the spot about perhaps the most intriguing possible morphing of the cardiovascular specialist lies in the development of percutaneous technique for the treatment of valvular heart disease. This is a self-fulfilling prophecy. Certainly, he was familiar with the Alain Cribier's work at that time, but it was quite an impressive prediction. The other thing that I think is still a little bit unfulfilled is this one. I see a blurring of the boundaries between disciplines and perhaps the emergence of new types of cardiologists, coupling ultrasound and radioisotope procedures with the new CMR and CT techniques could form the basis for the cardiovascular imaging specialist. That's what was quite an insightful view, and I think he's right on the spot in many things. So following that, there was a viewpoint from Dr. George Beller from UVA, where he basically, citing him, he put together and he started to organize how a multimodality training will look like. And you can start seeing this table that you're going to see in a couple of other documents in JAC, where basically he outlined how you could make it work, whereas you have cross-training of modalities and exposing one candidate to different modalities to create a thorough imager, cardiovascular imager. So his vision consisted of a couple of things. The first, it was a 4-year cardiology training for people that wanted to pursue non-invasive imaging. Integrated training in different modalities, meaning the candidate will be exposed to echo, CT, cardiac MR, nuclear. Collaboration between societies for integrated training path. So he saw that it was very important for societies to collaborate with, and to get this to fruition. Formal training and post-training path, meaning that he also describes some path after the person that is already a cardiologist and imager and want to pursue further training for them to have the opportunity to be able to become a multimodality imager. ACCF accreditation, for him this was very important and crucial because it kind of formalized the training in an organized fashion. As we all know, most of the subspecialties that have boards associated with it, they're ACCF accredited. And ABIM certification or certificate of added qualification. So these 6 points are highlighted on his document, and from this you can see how the discussion of multimodality imaging started taking place. And actually there was a very nice document that was led by Dr. Pam Douglas, where there was several points made, and it was more like a friendly debate about multimodality imaging. So one of the things that she said that it really catch my attention is, while catchy, the precise definition of multimodality imagery remains unclear. For which Dr. Beller responded, the time has come to introduce new pathways for training that emphasize the multimodality approach. And also, Dr. Thomas Ryan and Alex Austin, they also had something to say about this. And they were very firm in stating that the single modality imager will serve as a teacher, researcher, thought leader, and trailblazer. Currently, the case is, and you can see that how things move in the direction where we're today, where our current most respected thought leaders, they're very focused in one single modality. So all this discussion took place in 2008, a document that was led by Dr. Jim Thomas and Dr. Bill Sugby. They basically outlined a very comprehensive document, whereas they give recommendation on how to make this right, how to integrate path, how to cross-training, and perhaps sharing some training time in making sure that the imaging candidate will be exposed to the different modalities, what are the core concepts that should be emphasized. And it was a very comprehensive document, and I welcome you, if you're interested in this, to take a look at it. It's very comprehensive. But in 2016, there was a major shift, and this was basically the ACC Imaging Council. They have this think tank of experts that they weighted in every different aspects of the current status of cardiovascular imaging and how the future looks like and what were the unmet needs. And part of it is that they highlighted to preserve or enhance the relevance of cardiac imaging in a value-based healthcare system. Very important to take into consideration that. Define the cardiovascular imager of the future. Ensure robust and innovative and research in cardiac imaging. So to support the research and make it stronger and more robust. Maximize imaging information and improve outcomes. But there was one caveat on this document, in my opinion, and is this. Basically, they moved away from the multimodality imaging approach, and they were recommending to redefine the cardiac imager based on the level of expertise rather than the number of imaging modalities that they practice. And this was a major shift and change in vision from what the ACC Imaging Council had and the discussions that I showed you before. And so there was a very interesting editorial rebuttal that Dr. Chandrasekhar, the JAG imaging editor, had with a couple of co-authors like Tom Marwick. And basically, they saw the value of multimodality imaging. And they understood that there's two aspects that they were focused on their discussion. One aspect was the clinical value. So this multimodality imaging approach should present clinical value to the patient and to the care, and outcome-based strategy. So they felt that the more knowledge that someone has on the cardiac imaging field or of the different techniques, the better you will be able to give unbiased recommendations, and the better you will be able to select the most appropriate technique. And outcome-based results, they really emphasize that. So after I read that, I get fired up, and I emailed Dr. Narula, and I kind of gave them my opinion about that. I think that this silos of expertise approach really, will not allow to progress further the cardiovascular imaging field. And this document really fired me up. But at the same time, there was a lot of good things that they discussed. So, so going into the training aspect, and I know some people here, I can hear the laughs, cardiovascular imaging, if you really want to be a multimodality imaging currently, you're going to be overboarded. And the burden of the board certification is quite extensive. So we're talking about, a total, if you consider that this is all initial certification, a total cost of $6,215. And that's the burden that is on a trainee, on a fellow, on a cardiology fellow. If they're interested in pursuing all this high-level expertise and be board certified. Now, I have to give kudos to the Nuclear Certification Board because, they have been able to, there's some added value certainly when you are nuclear boarded, you can be an authorized user. That's part of the criteria. But the other, modalities, really the only benefit is for yourself. I mean, certainly there's some places where you only read echoes if you're board certified in echo. But, from the compensation standpoint model and all of that, there's really no much movement of needle or impact on being certified in all this. And I'm telling you this as being certified in multiple modalities. So I think this is an issue that needs to be addressed. There's some efforts. I cannot disclose too much, but I'm part of the certification board of cardiac MRI. And I can tell you that there's some effort to make this simpler, easier. And I think hopefully we'll have an update in years to come, but I think this needs to be better for sure. But this is part of the training. And the strategies for education, I'm just now touching the educational component. For a successful multimodality imaging program, I think that the cross-training the technician is a very important way of doing it. And not all technicians, but there's some technicians that will be interested. And you can cross-train probably echo to do CMR. And that helps the program too because you have a different perspectives. And I think it makes the program better. Multimodality conference by disease process. So basically, when you are explaining a concept, it's probably better to do a case-based approach where you can see how the modalities fit rather than just do a single modality didactic activity. Core imaging physics lectures for the fellows. It's important to have some time to discuss the CT, the MRI, and all that. But there are certain principles that hold true for different modalities. Like, for example, the concept of perfusion. When you're talking about perfusion, you can talk about nuclear. You can talk about stress echo. You can talk about CT and MR. And I think that there's some concepts that are intermingled and basic. And I think it's important to focus on that. And for the fellow training and for their benefit, I don't believe that, if you want to be level 3 in 3-4 modalities, whatever you want to do is fine. But the problem is that one thing is the clinical focus, and the other thing is the research focus. Probably for the research focus, they need to be really, really focused. But you have to also be flexible. But I think that the important thing is that certainly, there should be path for people that want to do a little bit more in imaging. And I think that the program has to be flexible. And discussion of case-based based on cost effectiveness and clinical outcomes. Very important to highlight that. Why we're doing all this imaging. Does it make sense? Are we wasting? I mean, it's great. Sometimes you have cases where they have all these imaging modalities. And it's also good to discuss the cases that there was maybe a technique that didn't really add value. So, and that's part of the multimodality imaging aspect, the right test for the right patient. So keeping into the education topic, patient-centered format for cardiovascular imaging learners. This is a very nice research letter from Jace, where they basically had two groups of for fellows education. They divided or they randomized for patient-centered and modality-centered. And what they found was that the fellows that underwent the patient-centered, they had better integrative skills that were assessed by a quiz that was given after this learning intervention. So I think it's important, and the people that underwent the patient-centered format, they perform higher in integrative skills scores. So it's important to keep in mind that this probably is a good way of having people learn all the modalities. While you see the case, you learn the strengths and limitations of each technique and where it applies. As part of the training program, the core values, there are 4 core values. This is a slide that I shared from my friend Andrew Choi from George Washington University, where he has the 4 A's: affable, available, accurate, and appropriate. I think it's important to integrate that into the concept of multimodality imaging training. We not because we can do it, we should do it, right? It has to have indications. We certainly have to be available. We have to be accurate and be up to what is known through each technique. So I think it's important, and it's a very nice way of illustrating what core values should be for cardiac imaging. And this is a collaboration that I did with Purvi Parwani and Andrew Choi, where basically we all work with radiologists in our home programs. I have a very great colleague, a radiologist, Dr. Greg Gladish, and we co-direct the program, and we have a very good thing going on. We're very collaborative. The thing is that when you see the radiologist and the cardiologist, we have very different training paths, and they're experts in lung pathology. Like, I know I can identify, oh, this is abnormal. What do you think? I will talk to Greg. What do you think, Greg? You know, and I because that's beyond my capabilities. At the same time, the hemodynamic knowledge that a radiologist have, and you know, it's not really what the cardiologist has been exposed, because we really, during our training, we are very exposed to hemodynamics, to invasive procedures, to certain pathology. So I think it's important for us to collaborate because we're coming from different places, but I think the successful program should have deep collaboration with radiology because, you know, I think we need them and they also need us. We certainly can increase volumes by referring patients, and we have the knowledge of the cardiovascular pathology, and they have other skill sets. So I think it's very important to wake that in. And again, not all radiologists are the same. There's some radiologists that they have a really strong background in cardiac imaging, and they're basically, you know, very good at it. So not saying that, you know, that will be a limitation, but I think it's important to collaborate, really. And this is a very nice slide by Prashant Nagpal, where in Jaha, he kind of had similar feelings, and he put together a nice document about collaboration between cardiology and radiology and what the core values should be in regards to patient care and all these shared goals, basically mutual collaboration, and how organizations need to work closer, like ACR, the American College of Radiology. I think they should work a little bit more with ACC because it's very important. This is a field where we have a lot of patients in common, and there's a lot of patients that are not benefiting just because of the resources are not available, and not the technical resources, because we have CT and MR everywhere else. But the problem is that, you know, we don't have qualified people that could oversee these programs, and there's a big need of this in our field. But these are not, the collaboration with radiology is not the only thing that could be a barrier if it's not the right collaboration. It's collaboration within cardiology. And I put together this diagram just by showing how usually you have the echo lab, the nuclear lab, the CT lab, and the cardiac MR, and it's all separate. And the person in the middle is like, what test should I order? What's going on with amyloid? I have a patient that I think suspecting amyloid. well, we have echo, we have PYP, we have MRI. I'm not sure what to do. And then this often creates some confusion in different other diseases process. But how it should be the imaging modality should coalesce, and our goal should be the patient and the best test for and the right test for the right patient. So I think that the collaboration within the cardiology department is very important, and we have to work together. Otherwise, the silos approach is just gonna create more problems than anything, and waste. So the way I see that, and this is a slide that I put in a blog, so I'm kind of stealing my own diagram. So basically, this is a disease-based approach to cardiovascular multimodality imaging, whereas you have clinical presentation, and echo usually is the gatekeeper because it's the most accessible, cost-effective way of looking at patients most of the time. And then from there, you build up, and you can certainly, depending on the disease process and the imaging protocols, then you can go to CT, to MR, nuclear, and the other modalities. So I think the echo lab should be, if anything, should be a way to identify which patient will benefit more from an additional imaging modality. Because it is kind of sad. You have a patient with LVH, and for a couple of years now with heart failure, and you did an echo, and a little bit of LVH and all that. And then it got worse, and then it's a patient with amyloid that maybe there was some abnormalities in the strain or something, and nobody identified that, and nobody identified the benefit of maybe referring this patient to PYP scanning or to CMR. So I think it's important to put in context the different protocols and what tests should be indicated, what should be our next step, if indicated. This is just a diagram, kind of showing the anatomical and the functional imaging aspects and the strengths and limitations of invasive angiography, CT, and perfusion imaging. And what I can tell you is that all these things, and now we're getting into the standardization multimodality imaging aspect, is that now I think that Scott Hart certainly has brought up and I'll talk a little bit about that, has brought up the debate between functional and anatomical imaging, which I find quite interesting. But I think this is just to put in perspective that you can discuss cases by using a multimodality approach, just by discussing a case and then showing slides like this. This is a comparison of this and that, and these are the strengths and limitations. And it's a busy slide, but I think it kind of illustrates the concept of anatomical versus functional. Multimodality imaging in heart failure, amyloidosis. I mean, this is a great, by the way, this is a great paper, more like a review article by Dr. DiCarli. And he has several examples that I'm going to use because I think these are really good. And especially in amyloidosis, we have echo, and there's the apical sparing and the LVH. And then you have the MRI with ECV and late gadolinium enhancement and ECV. All of them are prognostic. And then you see the PYP. You can basically, nowadays, if you exclude light chain amyloidosis with the serum free light chains, if they're negative, you basically do an MRI. Oh, this looks like amyloidosis. You do a PYP. This is TTR. You can start treatment without doing a biopsy. So it's quite interesting how imaging is stepping up and is replacing other invasive modes of diagnosis. Multimodality imaging in valvular heart disease. I mean, TAVR, now the different transcatheter valves, and it's all the planning that requires with the CT, with the 3D echo, all the information that we need. This is really multimodality imaging at its best. Not only that, but if you have a case where you're like, this is severe MR, I'm not sure, and you're evaluating a patient with a mitral clip, you can do an MR and do volume quantification and have very accurate numbers that will help guide you the decision tree algorithm. So I think valvular heart disease for multimodality imaging is very important also to consider. Multimodality imaging in heart failure, cardiac sarcoidosis. This is a case that we had. Basically, a patient MRI looked sarcoidy, but had some patchy and some transmural areas. So we did the PET, and we certainly, had the patient have the dietary preparation, all that. And all the LGE segments, basically, all the segments that were enhanced, they were avid. So this is consistent with sarcoidosis. And but this is kind of nice how you can see that, a couple of years ago, you will talk to certain people and say, hey, do you have PET-MR? Are you doing cardiac? Why? I mean, this is an overkill, PET-MR. Who really needs that? I mean, this doesn't make sense. But in this very important work by Mark Dweck from UK, he found value on doing PET-MR and how easy you can intermingle the LGE findings with the FDG avidity finding. So I think PET-MR is also an untapped resource and something that should be really look for certain applications. So I think it's quite interesting, this PET-MR thing, which I was kind of thinking the same way in the past. I was like, this is an overkill. But it turns out that it's not. Multimodality imaging, heart failure, myocarditis, secondary to lenalidomide. This is, I'm a cardio-oncologist, so it's kind of obliged me to show you a case of a patient with cancer. In this case, this patient had a lymphoma, and they were receiving lenalidomide, right? And in the MRI, you can see that there's, in the T2 weighted imaging, you can see a high signal in the basal aspect of the RV, and you can argue some patchiness in the ventricle. And then with the LGE, you can see a very strong leg ganglion enhancement signal. So you have the criteria for myocarditis. By MRI, you have edema, and you have the fibrosis. And we also did PET because there was a suspicion. Well, what about if this is an atypical sarcoid? But it turned out that it didn't really. It lighted up more in other areas, and even in the segment that had some enhancement, it was not that avid. So this didn't really match up as well. So I wonder what the imaging profile of myocarditis considering PET will be, and if that will help us to see how the patient will do. So this is just something that I wanted to share. And this patient had lymphoma, had lenalidomide, and had a lymphocytic myocarditis, which is kind of not very common. Anyways, this is just me making the case of multimodality imaging in certain clinical scenarios. So the influence of a multimodality imaging program should be based, and I think you guys have this the right way. It's basic translational outcomes database. You need to have those arms: institutional imaging registries and clinical trials, randomized multicenter. We need to move more towards have higher standards of evidence to validate our techniques. Because, for example, in cardio-oncology, the GLS is something that a lot of people do, and it sounds like it's a must to have, but at the same time, right now has been validated with very soft outcomes, and I think we need harder outcomes. And because the issue is that if you're gonna change the needle for treatment, if you have a patient that you have to stop chemo and the patient has cancer, you better have a good reason to do so. And I think that this is what in some fields is lacking in regards to imaging. But there's a lot of good work being done in different other places. For example, SCOT heart trial. You can argue, the event rate was low, but still there was a significant difference between standard of care in patients that had stable angina, between standard of care and the use of coronary CT, because it made people to start more preventive therapies early on. And I think these are the trials that we need to do. We need to validate what we're doing and find the value of the things that we believe in. MR informed, basically, patients with stable angina, the decision of PCI was deferred to either FFR or stress MRI, and there was no difference, meaning that making a decision to do PCI in patients with positive stress CMR has value. So I think this is the type of research that needs to continue to come and to show the value of these techniques. The Orbita trial, which this was a sham PCI versus PCI in patients with symptomatic angina and positive stress tests in some and very impressive positive invasive coronary angiography. And basically, this is just a sub-study looking at a placebo control, which is a very interesting concept, for at least for PCI and for drugs, it's kind of standard, but for PCI for procedures, it's kind of a trend that it kind of makes sense to me to pair these trials with imaging, because this was the validation of how bad a stress echo should be for you to select the patient that is going to benefit from symptom-wise from PCI the most. And I think that these are the things that we really need to look into. Great effort on this clinical trial where they randomized patients with non-coronary artery disease with either new symptoms or persistent symptoms to SPEC or versus SPEC. And there was no significant difference, and there was the acknowledgement in outcomes, and there was the acknowledgement that the study was not really powered to show superiority of either. So I think that this is very important, and these should be multicentric efforts in certain aspects. But I think that both techniques have a lot of value. But we need to start comparing and not be afraid what the result, where the data will take us. Dr. Velasquez knows this very well from his experience in the STITCH trial. I mean, we just have to go where the data take us. This is the way we make ourselves better. Ischemia trial, I see it more as an opportunity. Certainly if conservative is invasive in patients with stable disease, there's no difference. That gives us more opportunity to think and select which patient should benefit, and perhaps what we're doing right now maybe it's not the best thing, or perhaps it's just that the medical therapy is just really great, which we all think is the case. So I think I see ischemia as an opportunity to become more selective and perhaps re-stratify in a different way, and maybe that move the needles, maybe not, but I found it's all interesting. So the concept is to move from modality-centric, meaning echo is the best, or CT is the best, or MR is the best, to just patient-centric. And in reality, I've never met a radiologist that had told me every patient with abdominal pain, you just should do ultrasound. I mean, that, something like that sounds kind of a little bit off. I mean, why abdominal pain? I mean, just ultrasound. I mean, sometimes it's not going to give you the answer, right? So I think that that's the multimodality imaging aspect for us. I think we have to keep that in mind, that the patient really is in the middle of all this testing. And so basically, these are my kids. And I think we'll have to be collaborative and work together. And I think that will definitely move the needle and improve outcomes. Thank you.
Questions?
No, Barry, please. Dr. Barry.
Well, thank you for your talk. As a veteran of the cardiology, radiology, Cold Wars for many decades, I appreciate it and agree with you and have been advocating for this. Comment and a question that are related. As we do this, we run the risk of our research becoming more like the radiologists, where it's all case report and comparative studies. And I think that's something that we need to think about very clearly as we go forward. We need to do this. We need to have imaging centers. One of the other new areas in imaging involves molecular imaging, and that is using modern biologic approaches to design new imaging. And when we do this with a multimodality techniques, but there can be great advances if we do this in different ways, but look at the same biologic principles. We have a lot of strength in that here. What are your thoughts about how we deal with the intellectual and research issues of multimodality imaging with a particular emphasis on molecular approach?
So, I think that, a good example of what you're saying, for example, my conversation with Al has been that he's really doing a lot of multimodality imaging work. And basically focusing on the similar concepts or similar problems, but I think there's the potential to do collaborations, and I think that molecular imaging to me is very valuable, especially in a cancer center where I am. You know, I remember that I have done a couple of cases with carcinoid tumor involvement of the heart, and in MR sometimes, I mean MR is really what the technique to go when you have cardiac masses, but in this particular tumor, for a reason, I mean, sometimes the T2, T1 doesn't help that much, and the LG doesn't help that much. But when you use the PET dotatate agent, I mean, you see that this mass really lights up, and it's very evident. So I think I find a lot of value in molecular imaging, not only these niche specialties, but you know, special cases, but also, you know, when you want to determine tumor versus thrombus, I mean, certainly if in ultrasound you have some sort of molecular agent that you could use, and you know, and it could work, I think that would be great too. Because there's a lot of questions in endocarditis using the FDG and all of that, and more specific tracers. So I think molecular, there's a lot to do with that, but I think we certainly need to weigh the evidence with outcomes. And there's some, you know, smaller niche areas for molecular, but there's also other broader aspects. And I think the more you use a technique, and I think the more data you need to make sure that what you're doing is the right thing. I mean, especially for CAD. I mean, we make this decision on a day-to-day basis with CAD. I see a patient with a carcinoid tumor, you know, rarely, but there are certain things, the level of evidence have to meet the need of this technique. So the question for CAD is very important and basic to us. And there are certain scenarios where the level of data you need is not as robust as when you need something when there's a question for a randomized clinical trial. So I think, but there's a role certainly from what you're saying, for sure.
So Juan, thanks for your talk, and I guess I'm gonna try to borrow a little bit from your experience in a cancer center. We have diseases that we treat every day, as you've articulated just now. I'll use one example, like heart failure with a normal or preserved ejection fraction, where we clearly have a large population. We don't treat them particularly effectively, and we haven't really gotten to the heart of the disease process. And so I'd like to hear your thoughts about how you would, in a place like Yale, where we have fundamentally tremendous strengths in investigations, of how you would utilize multimodality imaging to follow, like we do in cancer,
sure,
where we follow a patient's trajectory and response to therapy, and can then modify therapies if the responses are not going in the same direction. Do you feel like we're going to be able to go in that direction for some of these common conditions in cardiology, like HFpEF, where we could use molecular or MRI findings of fibrosis or what have you to kind of start tweaking therapies in real time? So where do you see the field going next?
Great question, Dr. Velasquez. I think that, the issue with HFpEF, is that this is just an umbrella diagnosis, right? There's different other reasons why a patient is going to have HFpEF. And from recent data and from, Marsh study and many others, I mean, there's a pretty large population of amyloid TTR that is around that has not been identified. And sometimes, if you try to do the same things you will do for a hypersensitive heart disease, this is not going to work in a patient with amyloid. So I think that the imaging phenotype for HFpEF has to improve. Certainly, the three letters are WHI. Why you have HFpEF? Why? What's the etiology? Certainly, there's different other etiologies, but I think that the way that you can use, for example, a big change that you can use that is actionable now is to have really good protocols to identify patients with amyloid, because about 10% of the population, with symptomatic heart failure with preserved ejection fraction could have amyloid, and if you try to do, and sometimes you see this patient with HFpEF and their blood pressure is great, everything looks good. So what's going on? I mean, and I think that curiosity, it shouldn't stay in that realm, that this curiosity, but we have to standardize practice. And I think part of it, it's kind of hard to treat everything the same way, whereas we know that certainly there's other infiltrative process that can cause HFpEF. So I think the first thing I will do, in a place like this will be, let's look for the amyloid. I know you guys are doing that, but I think it's very important because there's a lot of unrecognized amyloid, and it's very important, especially now with treatment, we have something that we can actually do for these patients, and it's proven that their outcomes improve, and there's many other drugs in the pipeline, and there's the case to be made for combination therapy at some point. So I think we have to look at this, and certainly the HFpEF approach should be why this patient has HFpEF, whereas not just by treating, I'm going to give you LASIK and let's see how you do, and you're doing better. And certainly the most benefit will be blood pressure control, but also you have to look for other things that could cause this.
So just in follow-up, of Eric's question with regard to, so Sanjeev Paul used contrast echo to look at intramyocardial blood volume, and some people feel that HFpEF is disease of the microcirculation. How do you see contrast echo playing a role in HFpEF, and how do you see contrast echo playing a role in the echo?
Well, I think that he has great work. I think Dr. Call has a great body of work. The issue is that, I don't think that, and this is my opinion. I don't think that assessing perfusion with contrast, with echo contrast, is really ideal, because you have better techniques that are probably more reproducible, and I think that, that certainly, that's a great, concept, but I believe that there are other techniques, and now with the newer specs that you can actually measure coronary flow reserve with these great cameras, I think, that, to me, the most robust way of assessing microcirculation for now is in the nuclear realm. So that would be my thought, really.
So thank you. I want to get back to some of the practical aspects of multimodality imaging. When you're a radiologist, or in some sense, when you're a single modality imager, you read what comes to you, right? And what you're advocating for is, in a disease-specific model, is trying to affect the tests that are ordered upstream. Right? I think that's what you're arguing for. And so, how do you, from an imager's perspective, when our testing is ordered by the clinician for specific CPT codes, how do you affect those shunting of patients as an imager to the test that you think is more appropriate?
I think that there has to be protocols. I firmly believe, for example, if in my institution, and I think I was talking about this with Dr. Price. How sometimes you have you order an MRI, and then you have all this checking boxes, and sometimes the best thing is just to have a protocol for cardiomyopathy, a protocol for amyloid. So I think there has to be institutional protocols, and we have to make it like we have to get together and thought out a clinical path on what will be the best path supported by evidence to the best of our knowledge. So I think the protocols will work that way, because the thing is that if you leave it to the person ordering the test, and then sometimes and the other thing is the availability. Like, as an imager, you have to be available. There are going to be questions about what is the right test to order, what should I do, this is my patient, what do you think? And when it comes to I think there was a discussion last night about cardiac imaging consult, please help, I'm not sure what's going on. And not necessarily has to be a formal consult, but it could actually be a conversation, picking up the phone, what do you think? Or if we're too busy, even email or some sort of, but I believe in protocols because of that, because it's kind of hard to, you have all this testing and what should I do next? And there's some guidance from ASNAC. They have a good document about how to image amyloidosis. So I think that the societies also have to help in that sense, and to help us standardize better our practice.
Can I follow up on that, because it's an important point, and for all of us. I think what's really crazy in a way is that we are depending on the individuals who have the least amount of knowledge to choose a test to answer a question that they think that test might answer. And we forget that the reason they're choosing that, they're actually sending us for the test because they don't have the knowledge, they want us to help them. Right. So I think the concept of protocols, I'll throw it out, it is maybe not a great example, but we have heparin protocols. It says, please keep this person who needs to have a PT between 50 and 70, and we provide nursing protocols on heparin. We need to kind of move to that construct and say, I have a patient with heart failure, and order almost a protocol that eyes approach to the evaluation of heart failure, wherever that can take. And I think there's a lot of complexity around the billing for that, but I think it's something we can resolve. But that's, I think, how we have to go, because it is crazy to think that we're asking people who actually don't have knowledge and we just are receiving and sit in the echo lab and say, we'll just read the echo, even though we don't know what they were, what they really wanted to answer. Maybe it'd be better to be sent for PYP tests for them.
And it comes out to the patient-centered approach, right? It's not what we need; it's what the patient really needs. What is going to really move the needle in regards to outcomes. And I think protocols are a good way. I mean, they're not perfect. I mean, and again, we have to be flexible too. But I think that having protocols for certain, referring doctors to help them and make the right decision, I think is a good decision.
I completely agree with what you said. I mean, the many acute centers, as you know, have developed these pipelines. As I actually showed you one time in Freedom, and I think they're going to actually present that and see what's the outcome of that is, how much the cost of all these pipelines. But I think this is something we really need to establish here as well.
If this talk was being given by someone within cost effectiveness or public health, there would be a discussion about the concern we have about expanding costs of medical imaging. And it actually is one of the priority areas that is focused on for actually cost reduction and waste. But then when we have an imager speak to us, they talk about all of the amazing high-end technology or molecular imaging or PET MRI, which is only about a $5 million machine.
Yeah.
So, and this is an important discussion actually when we talk about how we train our fellows and
right.
having an appreciation, given that we're a health system across all of Southern Connecticut, how do we consider the role of cost? So can you present to us how you balance this concern we have about actually delivering care to our population and cost awareness and effect on patient outcomes and the role of multimodality imaging?
I think that's a great question, and I think there's a misconception about the, multimodality imaging as a source of waste. I think we should be stewards. There has to be stewardship, the same concept that applies to ID, infectious diseases, with antibiotic, right? Where, not everyone can prescribe vancomycin, or certain or Cyvox, because that will be a waste. Maybe the patient doesn't need it. So I think it has to be similar concept. We have to be stewards of the resources because the resources are limited. I mean, someone has to pay the bill, right? At the same time, so that's one aspect of the equation. The other aspect is that dying is cheap. Unfortunately, so if you are, if you want to keep the value of what you're doing up, you also have to see what improve outcomes. And sometimes, that's money well spent if someone is going to do better. If you can identify something and change the needle, I think that, there has to be a balance, right? I mean, certainly not everyone's going to have these more uncommon diseases that will use PET-MR, I mean, this is not going to be a very, common test to order. But at the same time, there are some patients that, it depends what the patient needs. So I think it has to be value-based, but at the same time, the patient interest has to be in the center. And I think that, like you said, discussions about public policy, about the cost effectiveness have to be a fundamental part of a multimodality imaging program, because otherwise, if you do echo all the time, it can be cheap at some point, but maybe you're misdiagnosed that it's going to cost more in the long-term situation. So I think there has to be a balance, but these discussions are very healthy, and we need to keep having them. I think the value-based imaging is important.
So, thank you for your talk. Wonder if you could share with us the experience at your place, and then what you see is really within the mission of the academic medical center. It's a really simple question. Is multimodality imaging, is it really something that should be done in the academic center by multiple individuals trained in all motifs, or should this really be a multidisciplinary center of excellence where people are working together, talking together, seeing patients together? What's your view on that?
So my view on that, I believe multidisciplinary care is so important, especially in cardio-oncology, where I know certain things about the cancer and the consequences, but I don't understand well in depth how certain decisions are made in the oncology realm, meaning that I'm not gonna argue with oncology about a chemotherapy, because that's beyond my scope of practice. So we practice on a multidisciplinary fashion. And I think it's very important what you bring up. Like, we're not saying you can be an echocardiographer that is focused on a single modality track, but I think as part of being an imager, you have to also be aware of other modalities and how and when they're indicated and how they can help the diagnosis. So I think working as a team, I think we're going to be stronger. But at the same time, I think that the future of imaging, cardiovascular imaging, lies in multimodality, in the academic vision of that if you train an individual in certain modality, in different types of modalities, then they're not going to be afraid to do certain studies that need to be done and comparison head-to-head studies, and it's going to be a little bit less biased. Like if you have someone that is really very focused on a technique and it's not performing well, then the bias becomes an obstacle sometimes. So I think there has to be a balance, but work as a team, and the academic vision for a center like this is to prepare the imager of the future and the future imaging trialists and the future people that are going to impact policy and all that. And I think the future is on this well-rounded training.
So the training is one thing, but actually the career is a different thing.
Right.
So I don't think anybody would argue that imagers should be trained in all the cardiac
Right.
modalities.
Right.
The question is, within an academic center, is that sustainable? And is that person going to contribute in a way that somebody who's more focused on one or two rather than 5 modalities will contribute?
No, I think I think you have to be more focused, especially if you're gonna pursue a career in being funded in research. Certainly, you have to be a little bit more focused. But I think Dr. Sinus has this as a good example of someone that has a multimodality imaging contributions, in his body of work of CT, MR, nuclear. So I think that we have to be flexible, but at the same time, there needs to be a focus. But what I try to stay away is from absolutes, because it doesn't work for everyone that way. But I think that the focus aspect is very important. Sure.
Question on outcomes. I mean, it's tough enough with disease states and medications, whether drug A is drug B is better than drug B in terms of clinical trials versus observational things. That's difficult enough. But then when you take it back a step and you try to do with imaging, where you're trying to do a strategy versus another. I mean, where do you see this go? You said some clinical trials, but there's so few of them.
Yeah.
As well as all the observational data, it's really tough to figure out. So we talk about added value of one imaging over another, but even any imaging over no imaging, it's just not out there. How do you build that infrastructure? Where do we go for the future to ensure that we really are giving added value for our imaging?
Yeah, I think part of it, registries are a valuable option. Certainly, I mean, there's a big effort of ASNAC. They're have this initiative where they have multiple societies contributing to these imaging registries. So I think that certainly that's a way of kind of looking at the outcomes. It's hard enough to do a clinical trial, like you said. I mean, especially they're costly. I think this is not a single institution effort, but a multiple institution efforts, and at the same time, if you see, we don't have a lot of robust data at the level of some of the trials that I presented to you, and I think that's something that we have to discuss, and it's not going to be handled by one person, right? I think it's a vision of multimodality imaging, and I think a certain group of people that want to contribute to this body of work. But it's like you said, I mean, there's very few of this clinical trial, but every time something like this comes up, because it's so impactful and relevant, it makes it to a major journal, and the impact that it has, I think, is very valuable. So I think there has to be a path, and we don't have everything figured out, like you said.
Do you have a follow-up question?
A bit of a statement and then your comment on it would be great. This is more for us as a group to think about, because I think we talk about you're using the term patient-centered imaging. To me, what you're really describing is disease-specific protocolized imaging. And I would push back that as we think what patient-centered truly means is actually that the patient is part of the discussion of whether imaging is being pursued, that they understand how imaging will change their care, and they decide that that imaging is aligned with their values of their care. And so I'm pushing back on our use of patient-centered imaging in this situation. I want to differentiate that from disease protocolized, which really has an important role now that we're developing very effective specialty techniques in which imaging protocols are a part of that, and it's important for research. But when we say patient-centered, I think the patient comes way up front to decide whether it is even worth pursuing, per se, an echo, to understand whether they believe, the patient understands that will change their outcome, and they choose to join in partnership with their physician to go down that path, that there will be a question that will be answered, and that answer will affect their care. So it's not per se a question, it's a statement, but one for us to think about, and I welcome your comments on that.
I think you're totally right. I mean, maybe the better way to state it is more disease-based, but what I mean about patient-centric approach is that, it's not pushing for a technique because of the sake of it, but it's just that, any decision in regards to what techniques to use, you have to consider the disease of the patient, you have to consider the patient, but I agree with you. What you're saying is completely right.
This is a very interesting topic. So when I visited MD Anderson a few years back, the mission was to support oncology and to support patient care. Here, the provost writes that our mission is to create knowledge and scholarship and other things at the same time. So it's not the same in every place. And in a place like Yale, the question becomes, what's the role model that we want for our fellows and our trainees? Are we training the future leaders of any modality? And if you are doing that, how can you train in multiple modalities within a 2-year period and do research scholarship during the same time?
Yeah, I mean, it's a very good question. I think that the model that was discussed in 2008 on this JAC paper, this consensus statement about how to do the multimodality imaging, they discussed very well how to allocate time for each thing, and they really get into the details. Unfortunately, this document is a great resource, but it's still not that actionable because of certain other priorities. But I think that there has to be a path where you don't have to be level 3 in everything, right? I mean, certainly the important part will be to understand the strengths and limitations of each technique, and at the same time come with the good clinical questions to foster the research. So, but I'm not advocating, and I think we have to be flexible, right? For example, someone in structural imaging might be more interested in pursuing echo and CT because that's the most of what they do, and maybe they don't pursue MRI, but still it's multimodality imaging. So I think that there has to be a sensible way to make this work, and not, I mean, the cost and the time-consuming situation, because certainly if you want to have a highly skilled individual, it needs to spend more time. But I think there are paths and there's centers that are doing that. For example, where I train at Methodist, you know, they're doing multimodality imaging training. Here, they're doing multimodality. You guys are doing that. You know, Brigham is doing that, and other places, UVA. I mean, there's very good places, but there's very few people coming out of these training programs, and I think that's also, you know, what stagnates a little bit advance in the multimodality area.
And Miranda, I think the question you're addressing is the separation between what is the right clinical trained pathway versus how do you take the individuals that have been trained clinically on that pathway towards an academic career. And I think those are actually maybe separate issues, and I think 2 years is not sufficient, right?
Yeah.
But also, so we're all as general cardiologists. I refer patients for CAT. I haven't done CAT for 20 years, thanks God. So, I refer patients for EP, etc.
Yeah.
So the same basic knowledge of understanding what different modalities are, if I can understand what the issues with EP are, I should be able also as a trainee to understand what does MR do in general, without having even a level 2 training in MRI. I should be able to know, can I use MRI or not? I know, can I use CAT or not? Which one is more complicated?
Right.
You know, so we have to have that general knowledge.
Yeah, the level 1. Yeah,
So
for sure.
Just a comment. So we're uniquely positioned here in that we have an imaging T32 grant that actually will support people for 3 years. But I've never been able to get a cardiology fellow in 3 years.
Yeah.
So, but at least 2 years of sort of focused research in addition to advanced clinical imaging. That's the way, you know.
Thank you.
Thank you.